Welcome to Cardiovention. In this video, we'll explore the P wave and PR interval in ECG interpretation. These simple looking waves carry powerful insights about atrial and AV conduction. We will go into their physiological basis, normal measurements, and the clinical significance of their abnormalities. Let's get started. The P wave represents atrial depolarization, the electrical activity that spreads through the atria. It begins at the sinoatrial node located in the upper right atrium near the junction of the superior vena cava. The impulse then travels across the right atrium and reaches the left atrium primarily through Bachmann's bundle. This smooth wave of depolarization generates the P waves on surface ECG. At the cellular level, depolarization is mediated by fast sodium channels in atrial myocytes. Because both atria do not depolarize simultaneously, the P wave reflects this dual component pattern. Let's now discuss the normal features of the P wave. The duration should be less than 120 milliseconds or 3 small squares. Amplitude should not exceed 2.5 mm in the limb leads and 1.5 mm in the precordial leads. The axis normally lies between plus 45 to plus 75 degrees. In terms of lead appearance, lead 2 usually shows a smooth, upright P wave. Lead V1 typically displays a biphasic P wave. The initial positive portion comes from right atrial depolarization, and the terminal negative portion is due to left atrial depolarization. This biphasic nature is crucial for identifying subtle atrial enlargements. The P wave has two main components. The initial component reflects right atrial activation. The terminal component reflects left atrial activation. In lead 2, these often blend into a single smooth wave, but in lead V1, the biphasic shape helps us distinguish them more clearly. Understanding this division helps in diagnosing atrial enlargement and interatrial conduction delays. Let's move to P wave abnormalities. Right atrial enlargement, also known as P pulmonale, is seen as tall, peaked P waves, typically more than 2.5 mm in lead 2. It's often associated with pulmonary hypertension, COPD, or tricuspid valve disease. Left atrial enlargement, or P mitral, shows broad, notched P waves wider than 120 milliseconds in lead 2. In lead V1, you will notice a deep, wide, terminal negative component. This pattern suggests conditions like mitral stenosis or systemic hypertension. Inverted P waves in leads where they are normally upright, such as leads 2, 3 or AVF, suggest an ectopic atrial rhythm. Absent P waves may occur in atrial fibrillation where you will see a chaotic baseline. It can also be due to sinus arrest or SA block. Next, let's talk about the PR interval. It is measured from the beginning of the P wave to the start of the QRS complex. It reflects the time the electrical impulse takes to travel from the atria through the AV node into the His-Purkinje system. This includes the intra-atrial conduction, the AV nodal delay, and early ventricular conduction. The normal PR interval is between 120 to 200 milliseconds or 3 to 5 small squares. This brief delay at the AV node is physiologically essential, allowing the ventricles enough time to fill after the atrial contraction. Let's now discuss abnormalities of the PR interval. A short PR interval less than 120 milliseconds may indicate Wolff-Parkinson-White syndrome, where there's pre-excitation via an accessory pathway. You will see a short PR, delta wave, and a widened QRS complex. Or Lown-Ganong-Levine syndrome, which shows a short PR with a normal QRS and no delta waves. Short PR may also be seen in junctional rhythms. A prolonged PR interval greater than 200 milliseconds indicates a first degree AV block. This may be physiological due to beta blockers, calcium channel blockers, digitalis toxicity, inferior MI, or age-related conduction fibrosis. A variable PR interval suggests second degree AV block. In Mobitz type 1, also known as Wenckebach, the PR gradually increases until a QRS is dropped. In Mobitz type 2, PR is constant but intermittent non-conducted P waves appear. In complete heart block or third degree AV block, the atria and ventricles beat independently and PR intervals vary with no consistent pattern. Let's summarize. The P waves represent atrial depolarization with normal duration of less than 120 milliseconds, amplitude of less than 2.5 millimeters in limb leads. V1 shows a biphasic P wave that helps differentiate atrial abnormalities. The PR interval includes the time from atrial activation to ventricular activation. Normal range is 120 to 200 milliseconds. A short PR suggests pre-excitation or ectopic rhythm. A long PR suggests AV nodal delay. Clinical context is key. Always interpret these findings alongside symptoms, heart rate, medications, and rhythm analysis. Thanks for watching Cardiovention. If this video helped clarify the P wave and PR interval, give it a thumbs up and subscribe. Drop a comment if you would like us to cover AV blocks, QRS morphology, or ventricular arrhythmias in our upcoming videos. Until next time, keep reading ECGs and keep learning.